Hello and welcome to another episode of the Ather Talk podcast, the podcast series hosted by the EAS Young Fellows. My name is Svetlana Stoica from the Institute for Cardiovascular Diseases in Timisoara and Victor Babeș University of Medicine and Pharmacy, and I will be your host for today's episode. We are happy to have today with us in Glasgow at the 93rd EAS Congress Professor Michael Shapiro, who is the inaugural Fred M. Parrish Professor of Cardiology and Molecular Medicine at Wake Forest University, United States, where he is faculty in the section of cardiovascular medicine. His clinical interests focused on genetic and acquired disorders of cholesterol and triglycerides, atherosclerosis imaging, genetic predisposition to early heart attacks, and cardiovascular risk assessment in apparently healthy individuals. He is now director of the Center for Preventive Cardiology at Wake Forest Baptist Health. Hello, Professor Shapiro. It is a pleasure to have you here today to discuss your trajectory and your opinion on the future of cardiovascular research. On behalf of the EAS Young Fellows, I would like to thank you for accepting our invitation.
Yes, thank you, Svetlana. It's a pleasure to be here. I'm really delighted to have this conversation.
In this series of interviews, we want to give our listeners the chance to get to know more about you personally and about your research and academic career. So, could you please introduce yourself to our listeners? Who is Michael Shapiro?
Yeah, certainly. So I am a preventive cardiologist and really dedicated my career to understanding the biology and clinical processes that underlie atherosclerosis and cardiovascular risk. I currently serve as the director for our Center for Prevention of Cardiovascular Disease at Wake Forest University. And my work is really rooted in the belief that we can and must intervene earlier and more intelligently in the trajectory of cardiovascular disease. My clinical and academic focus is really the same and centers on lipid and lipoprotein disorders, atherosclerosis imaging, and prevention of cardiovascular disease. I also serve as our co-director of the NIH T32 program in epidemiology and CVD prevention at Wake. So I work very closely with our research fellows and mentor them. And I also am the current president of the American Society for Preventive Cardiology. And more recently, I've been participating in the AHA-ACC Cholesterol Guideline Writing Committee, which has been really very gratifying. So me as a person outside of work, I'm a husband and father of two wonderful children. Beyond my family, I'm a huge fan of history, especially ancient history and Eastern philosophy, and a major coffee enthusiast. So I suspect that if I wasn't in the field of cardiology, I might be a barista. And in a former life, I was also a musician. I was studying music very seriously when I was growing up and through high school, and was accepted into a music program. But the practical side of me got cold feet, and so I pursued medicine in the end, and went to a liberal arts college where I studied molecular biology, and then went the pre-med route.
Thank you very much for all this very interesting introduction. Could you please describe a typical day in your life, if there is such a day, and explain to us how do you manage to balance your research with your leadership role?
Yeah, there probably is no such day, as you suggested. I think that no 2 days are really the same, which is really both the challenge and the joy of this type of work that we do. I usually get up pretty early, around 5 in the morning, and the first thing I generally do is meditate, and then I'll do some exercise. And when I get to work, I will generally spend the first 30 minutes or 40 minutes on emails and preparing for the day's meetings. And having this kind of structure and routine really helps me set the tone for the rest of the day. On my clinic days, obviously begin seeing patients in our preventive cardiology practice, where we manage complex lipid disorders, early onset cardiovascular disease, and individuals at high risk based on either genetics or imaging findings. And on the non-clinic days, generally in back-to-back meetings, whether it's research planning sessions, data analysis discussions, manuscript writing, mentoring conversations, or strategic leadership meetings for our center. But I do try to preserve blocks of time for deeper, uninterrupted work, which might be dedicated to either writing, developing new research proposals, or reviewing data. I also rely heavily on a great team, and I've learned that delegation is essential, as is trust. You can't micromanage. And so when you surround yourself with capable, committed people and communicate a shared vision, it does become possible to wear many hats without burning out. But perhaps most importantly, I've learned to say no to things, which I think, especially early in the career, can be very, very difficult, but is one of the most important skills that you can learn. You want to basically say no to things that are not aligned with your core interests. And again, that's not easy, especially early, but really it is essential to staying focused and productive. And at the end of the day, I always try to come home with enough energy to be present with my family, because that's really what keeps everything else in perspective.
That's quite a lot that you are doing. So, do you have any advice for those aiming to starting to manage multiple responsibilities at the same time? I mean, how do you manage to combine your clinical and research tasks together with so many leadership roles?
Yeah, I think it's very much related to the answer that I just provided before, which is to be intentional with your time and energy, and you need to decide really what matters most to you and allocate your resources accordingly. Time is one of the most precious resources we have, and so one of the biggest pitfalls I see early career physicians and scientists fall into is saying yes to too many things out of a sense of either obligation or fear of missing out. That's a common one. So there's opportunity cost. Every time you say yes to something, you're obviously saying no to something else. And the sooner you learn to be very thoughtful in that way, the more successful and sustainable your career will be. Second, as I mentioned earlier, I do try to create a structure where possible. And so I do block time on my calendar. So, my administrative assistant actually sees this. There's periods of time that are blocked on my calendar for specific things like writing, thinking, doing emails, and even exercising. Sometimes I have to actually put it into the calendar to make sure that it's done. And if you don't have that structure, it's too easy for the day to get swallowed up by other things, such as meetings and emails. And so I think it's also critical to separate urgent from important. Not everything that demands your attention is really worth it. Third, I would say you need to build strong relationships with mentors, collaborators, and especially with a reliable administrative and research support team, because what you're doing is really never a solo endeavor. And I've been fortunate that I've been able to work with incredibly talented and trustworthy colleagues. So I feel incredibly fortunate about that. Again, delegating, which is a super important skill because a lot of us like to micromanage things. Delegating does not mean that you're abdicating responsibility. It means that you're creating space to focus on what only you can do. I think many young academics feel an intense pressure to climb the ladder quickly. I see this all the time. And perhaps as I'm getting older, it has become more obvious to me. But there's a sense that every opportunity must be seized immediately, or that success must come early, or it's not going to come, which of course is far from the truth. And I do understand that urgency. I felt it, and it comes from your drive and your ambition and your hope, your aspirations. But I've also seen how that mindset can lead to burnout and disillusionment. And the truth is that this is a marathon. It's not a sprint. So if you stay working hard and you persevere, the rewards will come with time. And then finally, and I can't overstate this, is to not neglect your personal life. It is super important. So whatever balance means for you, and it means different things for different people, whether it's family, exercise, reading, whatever hobbies you like, time to reflect, those are the things that are going to sustain you over the long term. And burnout is real, and it should not be thought of as a badge of honor.
Now that we got to know you a little bit more personally, could you tell us more about your academic journey and what led you to focus studying atherosclerosis, lipids, lipoproteins, PCSK9, and generally cardiovascular diseases from the epidemiological point of view? How did your journey start and which obstacles did you have to overcome? You mentioned starting with music, so
yes,
tell us more.
That's exactly right. So I think my journey wasn't exactly typical, as you're suggesting. So, obviously then I went into university without really a clear idea of ultimately what I wanted to do. But I wound up becoming friends early on in my freshman year in college with a lot of individuals who were pre-med. And I sort of caught that bug and ultimately went in that direction. But when I went to medical school, again, I didn't necessarily have a clear plan of ultimately what I wanted to do. I did internal medicine residency, followed by cardiology fellowship. And even within cardiology fellowship, wasn't really leaning towards a career in research. I mean, I was involved with projects which I enjoyed, but I didn't at that time have a significant research training experience, I did know that I wanted to subspecialize within cardiology. And I looked at a variety of subspecialties, including, like, I think many cardiologists think about interventional cardiology at one point. But as that was getting closer and I thought about the lifestyle, I knew that I probably wasn't a perfect match for that. But when I was looking, it was right around the time that cardiac MRI and cardiac CT were emerging as serious imaging modalities in cardiology. And particularly cardiac CT was just getting to the point where the technology was robust enough to enter clinical practice. And I remember that during my fellowship, I went to several CMR and CT meetings, and I really, found it absolutely fascinating. And that's ultimately the direction that I went in. And so I actually looked for training opportunities in imaging. But at that time, first of all, there weren't many training programs for advanced cardiovascular imaging, and the ones that did exist were generally within radiology departments. So being a cardiologist applying to radiology programs, I was met with some suspicion, but eventually found a great place to train and spent a few years doing research and clinical training in those two modalities, CT and MR, and then took my first faculty position out in the West Coast of the US. And really, I was brought there to start an advanced imaging program and really, really enjoyed it. It was a great opportunity, especially for somebody who was just out of training. But ultimately, what happened is I went from radiology back to my home in cardiology. So I started thinking more clinically and not just being interested in pure imaging research. And that's where I started to get more interested, looking at atherosclerosis all day, every day on these modalities, particularly CT. I think a lot of us then, get interested in understanding lipids, atherosclerosis, and ultimately prevention of cardiovascular disease. That's certainly what happened to me, and that's where my interests were evolved. And then several years later, probably the most important mentor of my career entered the scene. Somebody was recruited to start a center for preventive cardiology where I was. And we hit it off immediately, both professionally and personally. And that's really accelerated my transition more from an imager to preventive cardiologist. And that's where I am today.
But did you always have the determination to work as a physician scientist, or this curiosity for research developed during later on?
Yeah, definitely later on. I think, like many of us, the reason I went to medical school was to take care of patients. I was drawn to the opportunity to build relationships and to hopefully make a tangible difference in people's lives. But the idea of research was not part of my early aspirations. It was only later during my postdoctoral training in imaging that my curiosity for research really began to emerge. And that was really a great time for me. And as I became more involved in the imaging research, I was really struck by the power of these tools to reveal hidden disease, plaques developing silently, patterns of risk not visible through routine labs or history alone. And I saw that research could help us answer many of these questions that I was asking in the clinic. Why do some patients with normal risk factor profiles have accelerated atherosclerosis? And on the other hand, what are we missing? How can we do better? So gradually, research became more than just an extra activity on top of my clinical work. It became really a principal interest in its own right. And over time, I found a deep fulfillment from trying to solve puzzles in real time. And I've come to believe that this dual lens, clinical and investigative, is really essential for advancing the field.
I would like to move on to another topic regarding mentorship. We all are aware that it plays a crucial role in many successful careers. So, did you have any mentors who influenced your path and whom you admired and directed your academic journey?
Yeah, absolutely. I think none of us can really do this on our own. It does really require somebody who's gone down the path before us. So again, really, it was during my postdoc training that I was kind of immersed in a more robust research experience, and I had several mentors who were really instrumental in shaping my development there. And they taught me how to ask the right questions and how to think critically and creatively, and how to write with rigor and clarity. And that foundation really proved invaluable as I began to navigate the academic landscape. I had sort of mentioned that as I was getting more interested, transitioning from imaging more to lipids and atherosclerosis, one of the most influential mentors in my journey was Dr. Sergio Fazio, and working with him really was quite formative for me. He helped to deepen my understanding of lipoprotein metabolism and the pathophysiology of atherosclerosis. But he also modeled the values of intellectual curiosity and mentorship. And he really showed me that science is not just about the data, it's about the people, the ideas, and impact. And he really exemplified how to lead with integrity and generosity. And that's really left a lasting impression on me. And importantly, I think that mentorship is not just something we benefit from early in our careers. It's really essential at every stage. I continue to have mentors today, both within my home institution and outside of it. And they continue to help me in that ongoing exchange of ideas. And support is part of what makes academic medicine so dynamic and fulfilling. So I think, each of these mentors that I've had the opportunity to work with opened doors, offered candid feedback, modeled excellence, and most importantly, provided encouragement. And their influence continues to shape how I now mentor other young people. And I do my best to try to pay that forward, not just by offering advice or feedback, but really by believing in people the way that my mentors believed in me. And I have to say that now, as somebody a little bit older, I would say that mentorship is probably the favorite part of what I do today.
Going forward about mentorship, now that you've mentored many students and researchers over your career, what sort of qualities do you look for in a promising researcher, for example?
Yeah, there are several qualities that I think many of us look for, and certainly none of them involve knowing all the answers at the outset. And so what really stands out to me is genuine intellectual curiosity. And, the kind of curiosity that drives someone to ask thoughtful questions, challenge assumptions, and explore new angles with an open mind. And I think maybe the way to sort of encapsulate that is to look for individuals who simply cannot be satisfied unless they can find answers. There's almost, you can see a sense of urgency among individuals to understand and to get to the bottom of something and to push beyond the surface. I think that kind of internal drive is difficult and it's not teachable. That generally is intrinsic to somebody, but when it's present, it really is unmistakable and often, I think, the strongest predictor of long-term success in research. And closely tied to that is perseverance. Research, of course, is filled with setbacks, detours, rejections. And I think that the most successful scientists and researchers I know are the ones who keep showing up, who stay engaged, who are willing to revise and try again. And that kind of resilience, I think, is essential. Then, of course, integrity is non-negotiable. It's not just about honesty and data reporting. It's how you conduct yourself with your collaborators, how you engage in peer review, how you approach your work. I need to know that I can trust someone, not just to do the work, but to do it ethically and transparently. And then, super important is being coachable. And that's all about taking feedback and sort of reiterating. People who can receive feedback not as criticism, but really as an opportunity for growth, that is a beautiful quality that I love to see. And that willingness to reflect and adapt and improve, I think really is at the core of every successful career. So when somebody combines all of these things, curiosity, grit, perseverance, integrity, I think there's really no limit to what they can achieve.
I wanted to move forward towards international collaborations, which I know you are involved in very many. What do you see as the main advantages of working across borders like that? And how did those opportunities come about for you? And for early career scientists, for example, who hope to build similar networks, so what advice would you give to them?
Yeah, I think working internationally across borders is really one of the most enriching aspects of a career. For me, both professionally and personally, they expose you to new ways of thinking, new methodologies, diverse patient populations. They push you to challenge your own assumptions and to refine your hypotheses in ways that certainly wouldn't happen in a more insular environment. And these partnerships help us to understand the global variability in cardiovascular risk, presentation, response to therapies, and I think ultimately make our research findings more generalizable and hopefully our care more equitable. So any of my international collaborations began really with informal conversations at meetings such as this, at the EAS, or through shared interest in data sets, trials, or sort of similar thematic questions. Sometimes it's a hallway chat after a session, or other times a mutual colleague, has made an introduction. And so when you reach out to someone whose work you admire, it is amazing how often they will respond. Compliments go a long way in actually opening up doors, especially if you come prepared with a thoughtful question or potential idea for collaboration. Now, for your specific question about, early career scientists, I think the advice is to be proactive, but also to be generous. In other words, don't just ask for favors, but, look for opportunities to contribute, whether through the, manuscript review, data analysis, helping organize a symposium. There's many ways you can lend a hand. And so you want to build your network by offering value to others, not just asking for favors. And when you do connect with potential collaborators, you need to be clear about your goals, your skills, and your commitment. And follow through is critically important. And then finally, remember that cultural humility and a willingness to learn from others, not just about science, will go a long way in building lasting and meaningful collaborations. I think a promising researcher is someone who sees the bigger picture and is motivated not just by publications or accolades, but by the opportunity to contribute meaningfully to the field.
That's a lot of insightful advice. I would like now to hear your expert opinion. For example, what do you think is currently missing in the way we approach cardiovascular prevention in younger or at-risk population?
Yeah, there's a lot to unpack with that one. That's actually one of my favorite things to think about, but I'll try to keep my thoughts, brief. I think there's really several dimensions to your question, and still today, I think we're falling short in how we conceptualize and implement prevention in younger or at-risk populations. I think, of course, to start, one of the most glaring gaps is our continued reliance on short-term 10-year risk models to guide decision making. These models dramatically underestimate, risk in younger individuals, and as a result, many high-risk younger adults are falsely reassured or go untreated until they already have significant atherosclerosis. I think as an imaging enthusiast, of course, we miss many opportunities to use tools like coronary artery calcium testing or coronary CTA to identify subclinical disease and elevated risk before events occur. Instead of focusing solely on LDL cholesterol thresholds or age cutoffs, I think we really need a more nuanced approach to risk assessment that incorporates biologic age, vascular age, lifestyle exposures, and the presence and extent of atherosclerosis, particularly in those that are developed in young. Another issue, certainly in the US, where I'm from, is that our health systems tend to be more reactive than proactive. And so we often wait until people who are asymptomatic have already developed chronic disease before intervening. And I think there really needs to be a complete paradigm shift towards prevention that begins in childhood and adolescence, that incorporates behavioral counseling, and that's delivered in a variety of community settings, not just in specialty clinics, which is just really seeing the tip of the iceberg. So in short, we need to stop treating prevention as something that starts at age 50. The seeds of cardiovascular disease, are sown early, and the earlier we act, the more lives we can help.
Indeed. So, what has been the most surprising or paradigm shifting finding in your research career so far?
Yeah, very much related to sort of the last question, which is that the extent to which subclinical atherosclerosis imaging redefines risk in a way that traditional risk calculators, often fail to capture. So for much of my training, we relied heavily on risk factor-based algorithms, LDL cholesterol levels, blood pressure, age, smoking status, to estimate who is at risk for cardiovascular events. But once I began working with imaging, CAC scoring, coronary CT angiography, it became so clear how much hidden disease we were missing and how dramatically these imaging modalities could help us reclassify risk. And so the discovery that individuals with high LDL and a CAC score of 0 may actually have lower short-term risk than someone with a normal LDL cholesterol but extensive CAC was a wake-up call. In other words, would you rather have a perfect LDL and a CAC score of 400? Or would you rather have a high LDL and a CAC score of 0? And I think that we would all answer that the same way. And it really fundamentally challenges the treat the number approach and emphasizes the need to detect the disease itself rather than just manage the risk factors. Another, concept that I like to challenge. This is the whole notion of residual cardiovascular risk, which implies that if we were just aggressive enough in individuals who had ASCVD, and if we just have the appropriate cocktail of therapies, we would be able to bring that risk down maybe close to zero. But I really don't think that's the case. I mean, I think despite progress and lowering LDL cholesterol, and now we can get everybody's LDL cholesterol to essentially wherever we want it to be. And even if we can control, all the traditional cardiovascular risk factors, cardiovascular events are still going to occur at, unfortunately, a higher rate than we'd like. And what I've come to appreciate more deeply is that residual risk is not just a concept of a gap in therapy, but it often reflects the accumulated burden of disease, the plaque that's already formed, vascular damage that has already occurred in processes that may no longer be fully reversible. So it's actually the understanding that the greater the extent and severity of underlying atherosclerosis, the more residual risk may be present. However, much of that risk is now unmodifiable. So we need to shift our mindset from viewing residual risk solely as a modifiable target to recognizing it as a marker of advanced disease. And this reframing has significant implications because underlying that, it really underscores the urgency of earlier detection and treatment before irreversible structural damage has taken root. And it reminds us that once plaque is already developed, even aggressive risk factor modification may not fully eliminate the risk of clinical events. And that realization, I think, pushes us to think more deeply about the timing and the trajectory of and the cumulative nature of cardiovascular disease.
I would like to touch another topic before we end this podcast. So, given your extensive work on PCSK9, what do you feel are the gaps or overlooked aspects in the current research landscape?
Yeah, I mean, there's no doubt that the discovery of PCSK9 and its translation to a targeted therapy has transformed our ability to take care of the most challenging patients with hypercholesterolemia and ASCVD. But we need to remember that PCSK9 was identified in 2003, and the drugs targeting PCSK9 as a therapy were approved for use in 2015. That's a mere 12 years. That's a much shorter interval than most drugs go from bench to bedside. And as such, because there wasn't that much time to learn about the full physiology of PCSK9, I think there's several important gaps and areas that deserve greater attention. First, we don't understand the long-term consequences of sustained PCSK9 suppression, especially at very low LDL cholesterol levels. And although the safety data to date have been reassuring, most of the evidence from the clinical trials is limited to several years of follow-up. And so I think understanding the impact of much longer exposure to ultra-low LDL cholesterol, particularly in younger individuals, remains an open question. That said, I'm not particularly concerned, but it is an open question. And then I think we've really only scratched the surface in understanding the pleiotropic effects of PCSK9. Of course, we have a very good characterization of its role in LDL receptor degradation, but there's emerging evidence that PCSK9 may have direct effect on inflammation and thrombosis and even vascular biology. So those potential non-lipid pathways potentially could help explain some of the cardiovascular benefits observed in the trials and merit further mechanistic investigation. Third, the current risk-based model for developing and deploying PCSK9 inhibitors, particularly given their cost, has limited access primarily to patients with very high risk or established disease. But there's a growing recognition that it's this lifetime exposure to LDL that may offer a more rational framework. In other words, identifying susceptible individuals early and treating them before plaque accumulation, I know I sound like a broken record, would probably yield much greater absolute benefits. But again, this requires a shift in mindset, infrastructure, and reimbursement models. So unfortunately, for the most part, today, only patients with advanced disease are getting access to PCSK9 inhibitors, and I believe there are many more individuals who would benefit to help them prevent ASCVD. And then finally, we need to address the disparities in access to these therapies. And, despite strong evidence and clear guideline support, the real-world data show that underrepresented and underserved populations remain less likely to get access to PCSK9 inhibitors. So as with any innovation, equity must be central to the implementation strategy.
Indeed, you are right. So let's move on to future perspectives. What emerging trends or technologies do you think will shape the future of research in your field?
I think there are many exciting trends that I think are really going to redefine cardiovascular research and prevention in particular over the next decade. Of course, there's been a lot of interest in integration of multi-omic data into clinical practice. We're not there yet, but if this can be solved, this may be a game changer, certainly for risk prediction. If you could layer the genomic, the transcriptomic, the proteomic, the metabolomic, maybe even the microbiomic data, we could, have a better understanding of the biologic drivers of atherosclerosis at an unprecedented level of resolution. And this not only could help for risk prediction, but could help unlock new therapeutic targets, enable earlier detection of disease, and potentially allow us to personalize treatment in ways that are simply not possible today. Another major force that everybody, of course, is talking about is artificial intelligence and machine learning. And this is not just about automating tasks. They really have the potential to extract meaning from complex, high-dimensional data sets in ways that we simply are not able to do. And so from identifying novel biomarkers to improving imaging interpretation and clinical risk prediction, I think AI will be really a key partner in discovery and delivery. Imaging, we've talked a lot about imaging, but it actually continues to evolve, rapidly. And we're, moving well beyond coronary calcium scoring to much more advanced plaque characterization, including non-invasive identification of high-risk plaque features like lipid-rich cores or thin fibrous caps. So coupled with longitudinal data, these, insights will help us move from just the static snapshots of risk to dynamic monitoring of disease activity in response to therapy. What we're doing today with imaging is really getting a barometer of vascular health at one time point, but we're not really able to do disease tracking. With the advances in imaging, I think we're going to be able to do disease tracking in a meaningful way so that when you put somebody on certain therapies and you track their disease progression or even regression, you can then appropriately make changes to therapy based on what you see in imaging. I think everybody's very excited about base editing and gene editing approaches. They obviously hold extraordinary promise, specifically for monogenic lipid disorders like FH. But of course, they raise questions about safety, ethics, durability, and equity. So the field will need to engage not just with the science, but also with the societal implications of these powerful tools. And then I think finally, we're on the cusp of a digital health transformation. Wearables, biosensors, remote monitoring, mobile applications, they're really enabling a new era of continuous cardiovascular surveillance and to a large extent, patient engagement. Patients are constantly asking me about this. And so the challenge will be to ensure that these tools are evidence-based, and we're not there yet, that they're interoperable and equitably distributed.
Within this podcast, we also want to inform our listeners about the possible open positions in different academic institutions around the world. So, how do you usually announce your open positions, or would you encourage researchers looking for a PhD or a postdoc position to write directly to the labs they are interested in? How does it work for your institution?
Yeah, at Wake Forest, we certainly do post open positions through the formal university channels, particularly when we're recruiting for larger initiatives or funded postdoc programs. But, I think many of the most meaningful collaborations and opportunities for mentorship actually begin informally through direct outreach from prospective trainees, as we've talked about throughout this discussion. And so I absolutely encourage, young researchers, young scientists, young physicians who are passionate about prevention and atherosclerosis to reach out directly to individuals in the field. I think that an email that clearly conveys your interests, your background, what draws you to that particular lab or opportunities can really open up doors that a job board never will. And in fact, for me personally, some of the most talented people I've worked with have joined our team that way by taking initiative and starting a conversation. So again, at my institution at Wake Forest, we strongly value mentorship, and we're always looking for motivated individuals. who want to contribute to our mission. So even if we don't have a funded open position at the moment, we're often able to explore other mechanisms through training grants or fellowships or collaborative projects. So my advice is don't wait for perfect listing to appear. Reach out, introduce yourself, and share your passion, and you never know where that might lead.
Thank you once again, Professor Shapiro, for sharing your time and insights with us. Also, a big thank you to all our listeners. This podcast is for you, and we need your feedback to tailor it to your interests. So please don't forget to leave us your impressions and stay tuned. And again, thank you very much, Professor Shapiro.
Thank you. It was really a delight to be here with you today, and I hope you get a chance to enjoy the meeting. And I think what the EAS Young Fellows is doing is very inspiring. So keep up the great work.
Thank you.